Welcome to this course on the AACD Virtual Campus, where we will be showing a live patient demonstrating direct composite veneers. I handpicked this case because I felt it represents a good example of what is one of the most challenging parts for the accreditation criteria for dentists, the dreaded case type 5, 6 or more direct composite veneers. My goal is to help you learn and understand the fundamental principles of proper treatment planning, case preparation, instrumentarium, layering techniques, and polishing that will lead to predictable and lasting results for your patients. The principles and techniques that will be presented in this video are applicable to every direct composite in the anterior segment, such as class 4 fractures, diastemas, peg laterals, worn incisal edges, large class 3s. It's even applicable if you are planning on only using one shade of composite. This kind of minimally invasive dentistry is becoming more popular and widely accepted by both dentists and patients, as materials and techniques lead to results that rival those of indirect porcelain restorations. I've found that most of my patients choose composite over porcelain because they love the idea of not having to drill their natural tooth structure. It's purely additive. The fact that composites are a bit less than porcelain is a bonus as far as cost, but their motivating factor to go with composites is to preserve their enamel, knowing that they can always transition into porcelain later if they need to. Now, let's use our time well and get to it. We've all learned that in order to produce successful dentistry, we must begin with the end in mind, and that requires proper treatment planning on our part. This is true for a single restoration up to full mouth rehabilitation cases. In today's case, we are doing direct composite veneers on teeth numbers 5 through 12. This is an existing patient of mine of many years who eventually expressed his desire to improve his smile and wanted to know what his options were. I explained that I really needed an hour consultation appointment to have enough time to evaluate his bite and take quality photographs and discuss all the different materials and options with him so that he can make an informed decision on what he feels best would work for him. Here are a few photographs from the consultation appointment. We can see that there is evidence of wear on his front teeth along with old existing composite fillings. We don't have time in this video to review occlusal disease, but the risks versus benefits of all restorative options were reviewed with the patient. For a detailed review of occlusion, I highly recommend watching another excellent virtual campus video, 10 Common Occlusion Traps by Dr. Nada Albatish. She explains in great detail what to look for when evaluating wear, occlusion, and joints. For this patient, the logical minimally invasive restorative treatment options are porcelain or composite veneers. Because this patient is a friend of mine, he was willing to volunteer for the composite veneers simply for the purpose of this video, knowing that at some future time, he will eventually need to transition into porcelain. Nevertheless, he still values very much the thought of preserving as much of his natural tooth structure as possible, and the direct composite bonding allows for that. So, alginate impressions were taken, and 2 sets of models were made from which I fabricated bleaching trays and a diagnostic wax-up. I do my own diagnostic wax-ups, and I highly recommend this practice to you because so much information is learned in the process. I learn that if I need to do any soft tissue modification to the gingival zeniths, if any tooth reduction will be needed, and if so, how much. I learn where addition of composite will look the best when dealing with excess spacing. Can I add only to the distals of the lateral incisors, or do I need to add partly to the distals of the laterals and partly to the mesials of the canines? I can evaluate how much of each tooth will need to be covered with composite, because not every tooth has to be fully covered. Ultimately, I know that if I can make it look good in wax, I can make it look good in composite. If I can't make the wax up look good, then there's no way I can magically be able to make it look good in composite. The two go hand in hand. I can think about which composites I want or need to use and which colors will be needed. Each case is unique. I evaluate characterizations such as incisal translucency, white spots, craze lines, chroma, and value. All of this goes through my mental checklist as I review photographs and complete the wax-up, and when the patient shows up for their appointment, I already have a mental picture of the final outcome and simply have to execute the formula.